Hi everyone, welcome to another SJMC Grand Round. I'm your host, Alan Tay. I just want to take you through some housekeeping slides before I will pass it on to all my colleagues. You can see the entire cardiology team on the side there. Today it's all smaller because the screen is a bit cramped. But anyway, I hope you're using a big screen device. Okay. Anyway, without further ado, here is the housekeeping slides. Today's grand round is about a patient's journey, and this is part one. Okay. And as usual, we would like you to use Slido for interactive Q&A. And to join us on Slido, please go to slido.com in your browser, or if you have the app installed, just enter the code 203124. If you use your QR scanner, you can just scan there and it will take you to the slido.com with that code there. And you'll be able to answer our Q&A. Just to get you all warmed up, I've got just a few poll questions well, appreciate if y'all can just go to slido.com 203124 and tell us about yourself. You're a GP, you're a specialist, you're a medical officer, or you're something else. Please poll. Thank you. Yeah, that's good. Yeah. We'll have about more than 15 at least responses, then we will move on to the next one. Mostly GPs as usual. Yeah. Okay. Okay. Thank you. Okay. Just another one. Just another poll. Tell us about your experience with the SJMC grand round so far. First time watching one. Oh no. Watch some. Anybody watch all or not? Watch most. Okay.
Well, some of them have watched all.
Yeah. Okay. Yeah. Thank you. Yeah, that's great. All right. So that's warming up, huh? Okay, that's now you'll be claiming points using the QR code for this live session, which will display only at the end of the talk. The code is valid for only 1 hour. So if you're watching not live, you can claim points by entering code words in the MCQs from our bulletin board. And the link to this is in the description of the YouTube video, okay? Or you can visit our bulletin board CME section, and then you can answer the MCQs and you can claim points even though the live session is over. And throughout the talk, I'll be displaying the code word at the bottom like this. Code word equals something, something, something. So you take note of it and you'll be able to claim points, okay? And the points will be displayed, the QR code will be displayed in the slide, this slide here. Okay, so without further ado, let me introduce the entire panel, and our chairperson for the talk is Dr. Jayamala. So welcome, Jayamala. So I'll hand it over to you.
Thank you very much, Alan. This is the 12th SJMC Cardiology Grand Rounds, and we'd like to thank all of you for participating and watching these shows. This is the entire panel, and this we did have, in addition to the cardiologists, we had endocrinologists, SP Chan, Hugh Family, we had gastro, Dr. Ganesalingam, we had Dr. Cha, Dr. Neurologist, Dr. Young, and we had dietitian, Nurul, and Professor Winnie, and not forgetting the great Dr. Alan Tay. This is our first anniversary, and this is a patient's journey. Okay, we have a whole lot of panelists there. So, starting. 56-year-old man comes for a medical checkup because his friend died recently of an MI. He himself is asymptomatic, no chest pains, but occasionally finds it difficult to breathe after a heavy meal. He has no past medical illnesses, only takes supplements, no other medications, non-smoker, no exercises but walks a lot at his place of work. He drinks alcohol socially. He is a foreman in an engineering company. Both his parents died in their 70s. He claimed of old age. Of course, we will not say 70 is old age now. He is slightly overweight. The blood pressure is 140/100. His blood sugars and lipids are as shown, and that is his liver enzymes. So the first question is to SP. Is there still a role for an oral GTT and or 2-hour PP? And the second question, what are the health risks of a pre-diabetic?
The answer is yes. There is a definite role for you to do a 2-hour postprandial here. He is a typical metabolic syndrome. His body mass index places him in the obese category. We know that in Asians, anything above 27.5 is an obese person. And you can see from the fasting glucose as well as the A1C, it falls within what we consider as the impaired glucose tolerance or pre-diabetic range. He also appears to have what looks like fatty liver as shown by the elevated AST and ALT, with the ALT increased more than the AST. So with a low HDL, he is the classic metabolic syndrome. So if you want to try and categorize him into what category he is, you may want to do an oral glucose tolerance test, or you ask him to do a 2-hour postprandial glucose test. And what are the health risks of pre-diabetic? Big problem. Even though he is pre-diabetic, he is at risk of progression to diabetes within the next 5 to 10 years of about 50% to 70% eventually. And on top of that, he is at an increased risk of cardiovascular disease. So he is a ticking time bomb for cardiovascular events.
Okay, SP. Shamruz. He came because he was worried about his heart. His friend just died. So how would you assess his cardiac status?
Okay, hello. Hi, everyone. Given his background and the story, the first thing I would do is calculate his 10-year risk of coronary artery disease. According to the ACC calculator, his 10-year risk is more than 10%. It's about 5%. And the other score that we can use is the Framingham score. For him, it's about 22%. So that puts him at the high risk category. And then the pre-test likelihood for him to have a coronary artery disease, to me, is intermediate given his symptoms, his age, and his sex. So definitely, I would want to do an ECG and at the very least, a stress test. Given his breathlessness at night, which could be atypical angina, I would like to get an echo to assess his LV function. Chest X-ray I may or may not do, but it can help to exclude other non-cardiac kind of diseases.
Okay, Choi, people, can you elaborate and tell us the difference? What do you mean by CV risk? And often patient comes to see us saying they're looking for blocks. Are they the same?
Yeah, thanks, Dr. Jaya. That's a very common question. I think a very important one as well. So I guess the difference between CV risk and blocks is technically the difference between functional versus anatomy. So when we talk about CV risk, we are talking about the odds of a patient getting a heart attack or any kind of CV events, and that usually has to do with the plaque vulnerability, or should I say the ischemic burden of the patient. Whereas the blocks is technically just a luminal description of the coronary artery. So I guess the simple way to put it is that
I can't hear you, Choi. Okay, let's move on. Okay, Shamruz. If this gentleman, the resting ECG is normal, his chest X-ray shows a normal size heart, stress ECG he achieved 90% of maximal heart rate for age. It's reported as negative. Now, Kanan asked me to put out these slides to tell us, to remind us what is a negative. This is just a J point. This is an equivocal, and this is a definite positive stress ECG. Okay, so Shamrus, stress ECG is reported as negative. What does it mean? What are its limitations? Is workload important?
Yes, I mean, definitely. I mean, stress test negative, you have to take it in context with the patient's symptoms and risk factors. I mean, we know the sensitivity for stress test range between 65 to 77%. So in some patients, this is quite low to actually diagnose and give prognostication in terms of coronary artery disease, especially if you don't do it at high enough workload. But on the other hand, if you do have ECG changes at low workload, then that can give you some indication with regards to ischemic burden in this patient who might or might not have coronary artery disease.
What are the limitations of a stress ECG?
I mean, it's not 100%. The sensitivity is about 70 to 75%. And then sometimes in some patients, if they can't run properly, you can't do a stress test. And some ECGs you can't really interpret properly if they have bundle branch block at the beginning or non-specific ST changes due to LVH or hypertrophy due to hypertension. You can't really do a stress test.
Okay, if the stress ECG is reported as positive, what does that mean?
I mean, if it's positive, I will definitely want to see the tracing and see at what workload is this positive changes does this happen. If this kind of patient with high risk factors, some symptoms, if it's positive, I will definitely investigate him further, either some sort of stress imaging or go for anatomical assessment to make sure there's no obstructive coronary artery disease.
Kanan, you have anything to add to that?
I think Shamrus has covered most of what I would have wanted to say. In this man, if the test is positive, one of the other things we have to think about is whether it's a false positive test because he has got hypertension. I think the rest Shamrus has covered.
Yeah, so you may also wonder whether it's false or it's a true positive. Cool. What if there were ectopics seen during the stress ECG? What is the significance of ectopics?
So, traditionally, when we look at stress tests, we interpret either the ECG changes, where it's the ST depression, the classical one, horizontal or down-sloping type, that is considered positive. But it is not really described very well about ectopics, especially when you see it during exercise. So when you look at all those studies back then, what has been noticed that if you develop ectopics, especially during the recovery period, the mortality rate is high, whatever all-cause mortality. And if you are during exercise, you develop the ectopics, it is very non-specific and it is poorly related to coronary disease. Now, some patients in the baseline, they have already had ectopics. And then when you do exercise, it disappeared, and then went back to recovery, and it is the ectopics came back. So these are mostly benign type. So let's say you see ectopic during stress test, unless you see a ST depression, unless the patient develops the angina or symptoms, then it's probably non-specific.
What if you develop VT during stress test?
Yes, that is positive. That is a classical description of when you should stop a stress test. If you develop even non-sustained ventricular tachycardia, the stress test should be deemed as positive and further investigation has to be done. The important thing is when you see ectopics, it can mean patient having a sympathetic overdrive, patient having sometimes ischemia. So it means that you shouldn't take ectopics lightly during stress test. You should follow up, and maybe sometimes, if, like for example, in this patient who has some shortness of breath, it might because of all these ectopic causing the shortness of breath, although may not be a coronary disease related, it may be just PVCs related.
Thanks, Go. Now, Choi, many doctors and patients themselves say they don't want to do a stress ECG. Waste of time. What are your views?
I'm not sure whether you can hear me well this time. I think I got a bit
okay.
of connection problem. Well, I feel that for this particular patient, like what Dr. Shamrus has mentioned earlier, he belongs to the intermediate pre-test probably category. And for this particular group, the stress test is actually very useful because it has a very good negative predictive value. So meaning that if it's actually normal, we can technically rule out significant ischemic heart disease in him. But of course, however, if you have a very low pre-test probability patient, maybe stress test can also give you a bit of problems because you end up having false positives sometimes, especially maybe female patients in particular. Maybe Dr. Kannan, you want to add anything?
I think both Choi and Chambrose have brought up very important points. If you look back in history, treadmill tests were done for the diagnosis of coronary artery disease in the high-risk population. Now, mainly because of commercial interest, treadmill test is done for everybody, including 20-year-old female rock climbers. They belong to a very low-risk subset where the risk of false positive test is very high and the accuracy of the stress test becomes very limited. So stress test should be done in the appropriate population where in which group the sensitivity and specificity of the test increases, and if appropriately used, the stress test can give us valuable information.
Thank you very much. Anything else, Choi?
If I may add, a lot of people, I mean, nowadays we do stress tests mainly to look for IHD, but we must not forget that stress test is also very useful for valvular heart disease. Like perhaps you have a patient with severe aortic stenosis, and the patient kept on saying, oh, I got no chest pain, I have no shortness of breath, I can do my work very well. Sometimes it's actually good to put him on a treadmill and you can see the BP dropping when he started running. Maybe it's a good indication and timing to get the valve replaced as well. And also some patients who have 2-to-1 block and they are young, we don't know whether this block is normal or is it abnormal. The simplest way is put them on a treadmill and you see the 2-to-1 miraculously change to the 1-to-1 conduction. So you know that his AB node is perfectly normal. So stress test is more than just ischemic heart assessment, and we should always remember that thing.
Thank you, Choi.
I would like to add something which is important. Choi brought up doing a stress test for people with aortic stenosis. One has to be very, very careful when you do that. In the traditional teaching, one of the contraindications for treadmill test is for patients with fixed stenosis like aortic stenosis. These are patients who will collapse and die during a treadmill, although a treadmill in vast majority of cases is very safe. So if you do it at all, you must be very, very careful and must be quick to stop the test even at a low workload. Personally, I would not do a treadmill test in somebody who has got significant aortic stenosis.
Thank you. All right. Now, Shamrus, you did mention about echo. Would you like to just say a bit?
Okay, I mean, in terms of echo, in terms of prognosis, if they have normal LV function, then the prognosis for this patient will be very good over the next year. But the other thing about echo, which is useful, it can also show any regional wall motion abnormalities or any valvular heart disease that can explain his symptoms. So his symptoms is breathlessness. So it may not just be coronary artery disease, it could be something else that's happening. But with regards to coronary artery disease, the LV function is important for prognostication.
Okay, I challenge you, Shamrus. This man's ECG is normal. Chest X-ray, normal size heart. Chances are his LV may be normal.
Yes.
So what would your reason be for doing echo in this man?
Well, to me, it's more to know the LV function. As I said, it's more for prognostication. If he has good LV function with normal stress test, then I can be more confident, over the next 1 year, for him to have any significant cardiac event, the risk will be very, very low. But the other thing for him, for hypertensive, you can also check for hypertensive heart disease, whether there's any left ventricular hypertrophy as evidence of end organ damage.
Kannan, you want to add to that?
I would say that I'm very old-fashioned and I'm very stingy with spending money. So I would go very clinical. If I'm not convinced there's any evidence of failure, if the ECG and the chest X-ray is normal, I probably would not do an echocardiogram. Although I agree that sensitivity for picking up left ventricular hypertrophy is far superior with echocardiogram as compared to left ventricle, as compared to an ECG. So the only value of echocardiogram in this man, in my opinion, would be picking up left ventricular hypertrophy, which has got prognostic significance. So if I elected to wait and watch to treat his blood pressure reading, if I saw left ventricular hypertrophy and echocardiogram, I said, well, I cannot wait, I should start treatment early.
Okay, what about Kelson score? Yep. You know, people always talk about Kelson score, CT angio. For the GPs, I will just show you what we mean by Kelson score. This is somebody whose Kelson score is 0. This guy has only one little spot, 29. This has got more, and this guy's is extensive calcification. When you do a CT angio, this is what the arteries look like. This is normal, and this guy has got a little plaque here. So yeah, back to you. He wants to know about Kelson score and CT coronary angio. What are your views?
Okay, so we have a 56-year-old man who has minimal symptoms of breathlessness, and he's got impaired glucose tolerance and some other risk factors, obese, and lipids are a bit high. Now, so far we've been talking about functional studies mainly, such as stress tests, where we actually looking for dynamic changes when you actually exercise. This class of tests now we are moving imaging, and if you've already done an echo and we've already discussed some of the usefulness of echo, then here is a chance for us to consider whether we should actually image the coronary arteries. Now, as Dr. Jaya has already said, the difference between a calcium score and a CT coronary angiogram, maybe I'll just elaborate a little further. Because when we are going to decide between these two, I think number one is we ought to discuss with the patient, explain to the patient what it means. The cost is different. So the calcium score itself is a more basic test where it's faster. We just need to use the CT machine and do a rather quick screen and look for calcium within the coronary arteries. This will give us some information about plaque burden as represented by how much calcium is there, so that we'll get a number from this. Now, the CT angiogram involves actually intravenous access. We have to set a line, we have to inject contrast, and then we can actually image the arteries. And the benefit of this is we can see much more clearly within the arteries. We can look at the type of plaque there is, whether it's calcium or mixed with non-calcified plaque, so such as atheroma, and we can see the degree of stenosis. So we're going to get a bit more detail. But the calcium score test costs about 600, and the full CT scan costs about 3,000. So I agree with Dr. Kanan about taking cost into consideration when we are about to consider this test. So in someone like this who has a normal stress test, a normal ECG, and very, very minimal symptoms, we got to think twice before we go ahead and do either a calcium score or CT angio. I will give this options to the patients and probably discuss with them whether they are keen to proceed to have a look at the coronary arteries or not. I don't think it's a straightforward yes or no. I don't know about what you feel, Dr. Kala.
I would agree with you. I think the calcium score in this man is not mandatory. As Shamrus pointed out, if you calculate his premium score, his CVD risk for the next 10 years is more than 30%, which is very high, which means that we're going to bang down all his risk factors down to target as according to the guidelines. So whether the coronary calcium score is 0 or whether it's going to be 300 makes little difference in terms of treatment. So I would say that the calcium score is not mandatory, but as the American College of Cardiology has pointed out, using a calcium score will help you further risk assess the patient, and they have shown that this using a calcium score can result in reclassification of risk up to 50%.
Could you try again?
Okay. I think we can continue, Kanan. We can hear you.
Okay, let me know if there's anything else I can help you with.
That's about all I've got to say.
Okay. So, patient wanted something more than just stress ECG. So he managed to convince you that his to do the calcium score, and it was done. It was 56. How would you interpret these results? And how can calcium score help with CV risk assessment? And will this change your management? I just show this to you, just to tell you what the different scores are and how that helps with your CV risk. And then, yep, you can ask first.
Yeah, so a score of 56 is lowish, but certainly there is calcium. So the lowest will be 0. And we do have quite a few patients who have a calcium score of 0. But in a patient of this age with some cardiac risk factors, I think 56 makes sense. It doesn't imply that there is any very serious coronary artery disease, although this is a calcium score without doing a full CT. I think the management probably still remains the same at the moment, because we are going to try and control his risk factors aggressively and continue to do so over the years unless the situation changes.
Okay, Kanan, you have anything to change?
As Yap mentioned, I mean, the calcium score is low. It just tells me that this man does have atherosclerotic coronary artery disease, and I'm not surprised at all. If you did simple clinical scoring, you would have already said what the calcium score is showing. And we must also remember that the calcium score is just telling us about calcified coronary arteries. This well could well have non-calcified plaques and may have several of them. As we mentioned much earlier, just assessing his risk factors clinically tells us he's a high-risk patient, and we are going to aggressively treat him. So this calcium score really does not alter our management very much.
If the calcium score is 0, will it change your management?
Certainly not. I mean, even if it's 0, it's just 0 at that point in time. 1 week down the road, 1 month down the road, you might develop more plaques.
So although the negative predictive value is very good, it doesn't mean that he doesn't have non-calcified plaque.
Absolutely.
Okay, yep. If it was not done, but if a CT coronary angiogram had been performed, what are the advantages and disadvantages of doing this?
Yeah, so I think we touched upon this. I look at this as the type of imaging, and the advantage. One of the advantage of actually imaging the coronary arteries is we occasionally pick up surprises, yeah, but it's rare that we will get surprises. But sometimes someone may have a fairly low risk profile, but when they actually do a CT, we are surprised to find that there are actually significant plaques, atherosclerotic plaques there. So one of the advantage I would say is when you actually go and look for something, you will actually find something. But equally, it turns out that this could be a disadvantage because there are many people with silent coronary artery disease and stable plaques that you image and you find, oh, there's a lot of calcium and a lot of plaques there, and you're not quite sure whether we should be doing something about it or not. So unlike stress test and echo, which is non-radiation based, I think the disadvantage of CT is that number one, you have some radiation, and number two, the cost, and number three, we actually need to watch out for the kidneys because we are going to give contrast, and contrast can actually worsen patients' renal function if they already have renal impairment. And as we know, many of our patients with coronary disease, diabetics, hypertensives, they have a higher risk of having kidney disease. So that's the advantages and disadvantages, essentially.
Anything you want to add to that, Kanna?
A few things. Yap has covered most of it. It was very interesting that American College of Cardiology in 2018, they put up 2 papers. One was written by somebody who was a proponent for CT angiography. The next paper in the following month was written by somebody who opposed the free use of CT angiogram for everybody. So very interesting. In summary, the person who was a proponent said very accurately that the CT angiogram is the most accurate non-invasive test available today for the detection of angiographically significant coronary artery disease. As most of us know, in 2016, the NICE guidelines came up very much supporting CT angiogram. In fact, they said that it should be the first test for all patients with typical or atypical chest pains, as well as those with non-angina chest pains but with a positive trend. They were guided mainly from data from the PROMISE and the Scott Hart trials, which essentially showed that when you do a CT angiogram, you pick up plaques. Because you pick up plaques, you give the patients more statins and more antiplatelet agents, and this during follow-up results in a decreased incidence of myocardial infarction. As Yap also mentioned, CT angiograms picks up plaques which will be missed even by an invasive angiogram, and whereas other non-invasive tests look for flow-limiting plaques, only a CT angiogram will pick up early plaques and also be able to tell you about the morphology of the plaques, which will help you prognosticate the patient. On the other hand, CT angiogram is a static test. It gives you no information about the physiological significance of a lesion, which is very important. And studies have also shown that by using CT angiogram, often you overestimate the degree of stenosis, which we also know from our own experience. It also overestimates obstructive coronary artery disease up to 60%. And CT angiograms also increase the rate of invasive coronary angiograms by 50%, increases the incidence of revascularization, that unnecessary PTCAs done by doctors with very little prognostic benefit. So we need to weigh both the pros and cons before we subject a patient to this procedure.
Okay, thank you very much for that, Kanan. It was very mind-boggling what you said. But coming on to the next question. Okay, so if a CT angio had been performed and it had shown a mixed plaque of about 50 to 70% in the mid-LAD and a 30% plaque in the RCA, what are your comments or what would you do? You just gave us proponents and pro and con. I ask you first.
Okay, good. I mean, to me, if you say 50 to
70%,
70%, if I did an invasive angiogram, most likely I'm going to find 40%. That's our experience. If you get a low number for CT angiograms, you can minus that generally. So to me, this man has got non-obstructive coronary artery disease. I would just treat him aggressively medically and not do anything more.
What about you, Yap? You have anything different?
Actually, I agree with Dr. Kanan, but just to explain to everyone what these percentages mean, maybe. So if you have in CT, if we have anything less than 50%, we probably categorize that as in a mild group. If they are in the 50 to 70% range, we'll say it's moderate. And if they are more than 70%, they are in the severe range. Of course, this is just a general classification. I think we need to look back at this case, and in this case, the symptoms are atypical. The patient does not, for example, have exertional angina, and it would suggest that this moderate lesion, the 50 to 70% lesion, is not significant. Additionally, the stress test is effectively negative. So I don't think this patient needs, for example, needs angiogram or angioplasty at the current moment. If he had significant exertional angina, I think we would probably reconsider and discuss with the patient other options. But at the moment, I think I agree with Dr. Kanan, we probably treat medically and treat his risk factors aggressively.
So basically, I get it that the both of you are trying to say you look at the patient's symptoms, his pre-test probability of disease, look for a functional test to look for myocardial ischemia, and that will help you interpret the results of the CT angio. Am I correct?
The most important thing is we must remind ourselves that we must go back clinical so that we don't screen every patient with a CT angiogram. We have seen CT angiograms being performed for patients who present with classical rotator cuff syndrome, shoulder pain. If we have seen CT angiograms being done for patients who have actually got a pneumothorax and no benefit at all. So we must go back clinical, listen to the story and the examination, and then intelligently choose the test that's appropriate for the patient.
Thank you for the reminder, Kanan. This is just to telling you about something about CT angio and CV risk. Okay, Shamrus, he wants a cardiac MRI because there's no radiation. He's worried about it. what are your views of cardiac MRI and CV assessment?
Okay, cardiac MRI is one of the tests that has been coming more and more over the last few years, but still limited by number one, cost, and number two, the availability. In terms of the sensitivity to assess for obstructive coronary artery disease, the sensitivity is almost 90%, and the specificity range between 85 to 90%. The negative predictive value for a normal stress MRI at 2 years is almost 98% for non-fatal MI and cardiac death. So the results are certainly good, but whether it's necessary or not, we have to go back to what Dr. Kanan, everybody else said. So it's always symptom first, do the basics. If really necessary, then you go further. But as I said, the main limitation at the moment, number one, is the cost and the availability.
Cool. What about this Holter monitoring for ST segment to see if he feels short of breath? Will it be useful?
Short answer, no. Because I think the ST segment in the Holter is far less sensitive than our traditional stress ECG. In fact, it's not recommended to monitor ST segment using the Holter. However, in particular condition, for example, if you suspect a patient has a vasospastic angina or Prince matter angina, where the stress test is negative, then a Holter may be useful to capture any ST changes during the time of symptom. So we still need to have symptom rhythm correlationship. For monitoring the ST segment per se is not recommended.
Thanks, Bro. Okay, Navin, we did talk about stress ECG, stress echocardiogram. What are the sensitivity, specificity, predictive value? People just want to know.
Okay, so just to be clear on the definition, right? So sensitivity is basically the ability of a test to correctly identify patients with a disease. And we talk about specificity is basically the ability of a test to correctly and identify people without the disease. And so if you actually go to the next slide, Dr. Jia, you can see here, right, for an exercise stress test, the sensitivity is fairly low, it's about 45 to 50%, fairly specific, around 85 to 90. But if you look at stress echoes, either exercise or even dobutamine, it's more sensitive. You can see the sensitivity in the range of about 80 to 85. Specificity is also quite high, right? So again, I think like what we discussed earlier, we have to look at the pre-test probability of the patient having a coronary artery disease. So, I mean, an exercise stress test is a good place to begin with, a simple test as compared to a dobutamine stress echo or exercise stress echo. But I guess exercise stress echo or dobutamine stress echo, it has highly sensitivity because we're actually using two modalities. We're also looking at the ECG tracing. At the same time, we're also looking at the echo images. We are looking for any hypokinesia after exercise. So, for example, for this patient who, if you had done a CT scan and there was a 50% lesion there, and then when you do a stress echo, either dobutamine or treadmill, you can actually concentrate on that region and see if there's any hypokinesia indicating obstructive coronary artery disease. Whether to do an exercise or a dobutamine stress echo, I think that depends on the profile of the patient as well. If the patient can't exercise for whatever reason, knee pain or something, and can't walk on the treadmill, then you can probably consider a dobutamine stress echo.
For those who are not aware, this is the normal stress ECG. When you do a treadmill stress echo, you also have a table here where after running, the guy lies on this little bed and they image your heart to look at rest and post-exercise to see any changes in wall motion. Okay, Troy, when would you do a stress echocardiogram, whether it's a dobutamine or a treadmill?
So generally, we do dobutamine stress echo when we can't actually do exercise stress test. So for example, patient is limited physically. So for example, they have locomotor issues, injury, fractures, or because of weight issue, they can't actually run on a treadmill, or because of ECG abnormalities, left bundle branch block, a pacing rhythm, or pre-excitation ECG, we choose dobutamine stress echo. or even sometimes with established ischemic heart disease, patients with multi-vessel disease, with a poor EF, we plan to revascularize the patient, but not too sure which arteries to open up. Then we can actually use some kind of stress echo, whether it's a dopamine stress echo or treadmill echo, to look at the ischemic segment. Then we can actually stratify and treat accordingly. So short answer, we'll do stress echo when we can't do an exercise stress test. Treadmill stress echo can be done just like anyone who can actually run on the treadmill. But if you
Okay, you have also again dropped off, Troy. But never mind, we'll move on. Okay, Ko and Naveen, what is your CV assessment of this patient based on the test done so far? Naveen, you want to answer first?
Well, basically looking at this patient, right? I mean, based on the stress test, it's negative. The calcium score is low. So CV risk probably low to intermediate for this patient. If you look at even the Framingham risk scoring system. But again, we have to look at the pre-test probability for this patient. So I think, he is pre-diabetic, his lipids are not well controlled. And I think besides that, his sugars were also elevated. So I think for the moment, maybe you can, stop here, right, and observe, but you have to keep a close eye on this guy. If there is any further symptoms, he may need more detailed assessment. So that's where things like, a CT angiogram and all that may be useful, or a stress echo.
Ko, you have anything else to add?
Sometimes when you mention it is low to intermediate, the patient might not even take a medication.
That is the problem.
But I think being a pre-diabetic definitely put them at least in a moderate risk. And of course, the stress test, if you're able to achieve 9 minutes, I mean, the prognosis is very good. Actually, the mortality rate for the next 5 to 10 years very low. And of course, you've got even a calcium scoring more. So probably a moderate risk.
That is the problem. If you tell the patient your CV risk is low to moderate, heart disease yet, you forget everything that SP Chan is going to tell him in a little while.
Can I interrupt?
Yes.
How can we call this man's CV risk low? I mean, we can say that
Intermediate.
Yeah, but we may say that he does not have significant coronary artery disease at this point in time. But like SP mentioned right at the beginning, this flow is already a time bomb.
Time bomb.
I mean, he might not need an angiogram, he might not require angioplasty, but he certainly needs lifestyle modification and probably medications to control blood pressure, control his sugar, need to control his cholesterol. So, to me, if you just calculate the Framingham score, it already puts his 10-year risk of myocardial infarct as 30%, which is very high. So, he certainly is high risk to me.
So that is something which is very important, that we all have to help SP hammer into the patient. She, of course, is going to hammer him properly. Okay, how would you manage and what are your target values for his glucose and lipids? SP is all yours now.
Right. We recognize that he is intermediate to high risk, right? Or maybe according to Kanan, is high risk. So it depends on his family history. It seems like he doesn't have a strong family history of diabetes. But having said that, he should, first of all, lose weight. Secondly, he should manage his blood pressure to better levels than what he's got at the moment. And the third is the cholesterols are the typical metabolic dyslipidemia that requires, probably in my estimate, I would believe that he would qualify for statin therapy because he is in that high risk group. With regards to whether or not I would recommend him to start on therapy to prevent his progression to diabetes, that is definitely something that you can consider. And the only drug that we have currently for that, indicated for that, is that Metformin. Simple, old Metformin, not expensive. And if the patient is, as you can see here, fasting glucose is elevated, A1C is really intermediate, anything above 6 is considered as you're going to have high risk of progression. You might want to discuss with him about taking glucophage or Metformin. So statin and Metformin, but first and foremost, lifestyle, as Kanan would say.
Okay. So, SP, listen to you. We took 1000 milligram Nocte and atorvastatin 20. 1000, is that the usual dose?
Absolutely. Yes, that is a reasonable dose. That's a moderate dose. Full dose is 2000 milligrams. And with XR, you can take it all at one go. But don't start at 1000 straight away, guys. If you do that, the floor lao sai, remember, the floor will hate your guts. Then you will actually be sensitized to taking metformin. So start on a low dose and go slow and push it up. 1000 may be sufficient, but you must remember that the diabetes prevention studies all went 2005 to 2000 milligrams. So if you think that is really high risk, you can even escalate it to beyond. And of course, I'm glad that he started the statin.
Okay. Now, what about his abnormal liver function test?
Oh, brilliant. Okay, for that, of course, the gastro or any general person would say, I need to see whether or not there is any other reason why his enzymes are elevated. Make sure he's not a carrier for hepatitis, which is very commonly seen in Asia. So just a hepatitis Hep B test would be necessary. And then, of course, make sure that he's not taking any supplements or any traditional therapies that might be causing this problem, because it's quite common for our Asians, again, to be taking a lot of junk for health. Okay, so this would, if everything is excluded, then he's got fatty liver disease. So, and here is just to show that if those of you who tuned in last month will know that we did this in detail. So the key, as the gastroenterologist would say, Dr. Ganesh would say, is to try and determine whether this fellow is NAFLD, which is non-alcoholic fatty liver disease, which is, although it's not benign, but certainly not as bad as if it were NASH, where you get non-alcoholic steatohepatitis, where you get a lot of disturbance in the liver pathology, and at the end of the day causes liver fibrosis, cirrhosis, and hepatocellular carcinoma. All right, but just remember that NAFLD, if it is non-alcoholic fatty liver disease, it increases your chance of dying of a cardiovascular event. You don't die of a liver-related event, but you die of a cardiovascular event. Okay, so those of you who want to know how to score this fella in terms of trying to see whether or not they have liver fibrosis, you can have two. Ganesh mentioned. So FIB4, FIB4 is only 4 characteristics, which is very easily available. Age, 1, 2 is platelet count, 3 is AST, 4 is ALT. Look for it on the internet. You plug it in those numbers, you'll come up with a score. If your score is in the table down there, it's less than 1.3. Very low risk for advanced fibrosis. Repeat the test every 2 to 3 years, hammer the floor, get lifestyle. If it's more than 1.3, this is an intermediate to high risk for advanced liver fibrosis. The higher the number, the worse the case. So these patients, you may want to refer to gastro for further assessment. And then the next score, which is just as easy, adds on to the 4 parameters that I gave you: age, platelet count, AST, ALT. But on top of that, you need body mass index, or you have that albumin, and whether or not the floor has got IGT or type 2 diabetes, a yes or no. And if you work out the number, and I've got it on table here, less than 1.1455. Again, this you plug it into the calculator that you get online. Then this fellow is got F0 to F2, means very low risk of fibrosis. If it goes above that, then it's intermediate risk. And if it's more than 0, just that one, the first one was minus 1.4. The one is a plus 0.7676. Then the very high chance the fellow has got fibrosis and scarring. Send the patient to gastro.
Okay. We'll talk a little bit more. What practical advice can you give this patient on weight management?
You know, the best research on NAFLD and NASH has shown that it is lifestyle. Anything that gets your weight down by about 10%, you're going to reverse that histology. So you don't listen to all these advertisements you hear on the internet, liver tonics here, there. You just lose that weight and the patient's liver pathology will improve. And everything else will improve as well, I'm sure. Okay?
Okay, yeah. What do you think about his BP, 140/100?
Yeah, so maybe I keep it simple. Our guideline tells us that any blood pressure for the average person, which is above 140/90, will be considered the beginning of hypertension. So this is borderline. Certainly, if you look at the diastolic figure, which is 100, it is elevated. So by definition, this is stage 1 hypertension. On the other hand, this probably is just a one-off blood pressure reading in the office. So I would like to just get a bit more information, especially many of the patients that come with borderline blood pressure, we ought to encourage them to do home blood pressure readings. So I think your next slide, Dr. Jaya, which you showed, actually has some readings there for his home blood pressure, which is around 130 to 135 or 85 to 90. Now, again, keeping it very simple because a lot of the numbers can be confusing. Elevated blood pressure for office BP is 140/90, but for home blood pressure readings, it is actually -5, so 135 and 85. So anything above 135 and 85 in your home blood pressure reading is considered hypertension. So certainly stage 1 hypertension starts from there.
Okay, Naveen, what do you think about his blood pressure readings? Do you think you would advise medications, anything at this point in time?
Yeah, well, I mean, looking at his parameters 6 months later, everything looks worse. Actually, his sugars has gone up, his cholesterol has gone up. I mean, I honestly don't think so. He's very motivated, and I don't know how much of lifestyle changes he's actually practicing. And if you go by the guidelines now, actually anything above 130/80 is already considered pre-hypertensive in some countries, and even grade 1 hypertension according to some guidelines. So looking at his risk profile, and we've established that his risk of developing cardiovascular diseases is at least moderate, I would probably advise him to start on some medication to bring down his blood pressure, and also for renal protective effects, probably ACE or ARB. That'll be my first choice.
Okay, all right. Okay, we'll probably be stopping here in the interest of time because this story is going on and on. So, SP, how will you now manage this man's sugar and lipids, and what target? And obviously, he didn't listen to you the first time, lah.
Yeah, I'm very sad. His A1C has gone above 6.5. That makes him likely to be already, frankly, diabetic. But just to remind everyone, if the patient is asymptomatic, no symptoms of polyuria, polydipsia, you need a second test that is in the diabetic range in order for you to diagnose diabetes. So you need to have a second test, whether it is fasting glucose above 7, random of above 11.1, or another A1C a month later at above 6.5. Then that patient is diagnosed as diabetic. But having said that, very sad lah. He obviously also not taking his statin, and his liver has got worse. So this is a patient that is not serious about his health, to be honest. Just one more point which I failed to make. The problem is a lot of people think that it's fat intake that causes the fatty liver. Wrong. It's carbohydrate, refined carbohydrate, that is pushing the lipids into the liver. So you need to ask them to reduce carbohydrate intake, not fat.
Okay, this patient's journey shall continue because of the interest of time, because we will not have time to carry on with what happened later on. But like I said, the patient's journey continues. And in summary, a person coming to a cardiologist may be asymptomatic, or he may have typical symptoms of ischemia or atypical symptoms. If it's typical symptoms, depending on severity, one may advise a coronary angiogram straight away for definitive diagnosis and to guide further management. Sometimes we sometimes do a functional test of myocardial ischemia first to number one, objectively document presence of ischemia and severity. Secondly, and more important, to convince the person and insurance the symptoms are cardiac in origin. Otherwise, the insurance company will ask, why are you doing an angiogram? If the symptoms are atypical or the patient is asymptomatic, as has been all my colleagues have pointed out, one should assess the pre-test likelihood of coronary artery disease. You can use your risk assessment tools, ACC, Framingham score, whatever you, and then decide on whether a test of myocardial ischemia alone is enough, or whether you need to do a coronary angiogram, a non-invasive angiogram, depending upon his risk scores and symptoms. But importantly, I'm glad they all have shared with you, all patients should be advised on CV risk reduction, smoking cessation, treating their glucose, BP, and lipids to target, manage the metabolic syndrome, and again, healthy lifestyle and weight management. So, I end this session, Matters of the Heart, from the people you know and trust. Next month, September, the first week of September, we will not be having a grand round because the National Heart Association of Malaysia will be having their virtual summit meeting. We continue the patient's journey in October, first week of October, and that session will be a 3-hour session where we will not only have the patient's journey, we have other things, and including a quiz. And of course, it is 3 hours. You will get more QR points for your MMA code. Back to you, Alan.
Okay, I'm going to share the Slido questions in a second. Okay. So I think the question number one is, what is the radiation dose of calcium score versus CT angio?
Would you like to answer that? Kanan? Yep, or Kanan? Yep.
Yeah, actually, maybe it's easiest to compare the dose of CT angio and calcium score to X-rays. So a simple way to say is that calcium score, because it's very quick, gives you as much radiation as several X-rays, just a few X-rays, but CT angio a bit more because the actual image acquisition part takes a little bit longer. More radiation is needed to go in, so I think the dosage is equivalent to probably about 20 X-rays. So CT angio a fair bit more than calcium score.
Okay, next question.
How often do we need to repeat a CT angio if the first one showed minimal blockage and the patient is 65 years old?
Okay, Kanan, maybe you answer that, Kanan.
Depends how much money you want to earn. I mean, there are studies to show that if you have progressively increased calcium score, then your prognosis is not good. And this is very variable from patient to patient. There is no guideline to say how often we need to repeat this. I would, my own thoughts are, if you have got a calcium score that's already elevated, it requires adequate medical therapy. Subsequent investigations are going to be guided by your non-invasive evaluation, because calcium score does not give you physiological information.
I think I agree with Kanan that after the first assessment, I tend to go for risk reduction. Make sure you bring everything down to target, and unless there's a change in your symptomology or for some other reason, that will dictate when I would repeat the CT.
Okay. What is the proper dosage of metformin in pre-diabetes?
What has been studied is metformin 850 twice a day. That is the dose that you would use also for diabetes.
Can Dr. Chan please show the slide of FIB4 to determine if the patient has liver fibrosis?
Huh?
I don't know which one.
No. He wants the slide. Okay.
This one again?
This the one?
Hang on, I will add to the
Slide
stream.
36.
Can go full screen.
Just Google
Google.
FIP4, because you know that it's not just the ALT divide, no, it's sort of like that
Square root.
square root.
So just put it
Just-
inside and press the
Take it into
button.
the calculator.
I think just Google for FIP4 calculator. And
Yeah.
there are some online sites like
Or
MedCal. Yeah.
NAFLD fibrosis score.
NFS. So
NFS fibrosis
NFS.
score.
Okay. Let's go back to does statin increase the calcium on calcium score?
Okay, maybe I can answer that. There are some studies which seem to indicate that the calcium score may increase because the lipids get fibrosed and then they get calcified. So people are not very sure how to interpret an increasing calcium score. Is it because the plaque is being modified and getting more stable? That may be one explanation. Of course, if the patient is not taking care of himself and all his risk factors are sky high, the increase in calcium score is because of progression of atherosclerosis. Sometimes it's difficult to know which.
I think, Jaya, just to add to that, I think there's also studies that have done serial CT to look at the regression of non-calcified plaques, and if see there is some improvement in terms of statin usage and if you control the lipids better. So that's a non-calcified plaques, of course.
So the non-calcified becomes calcified.
No, there's some regression.
Regression of the
Yes, with
non-calcified.
statins.
Can I ask a loaded question? Is there any statin which does this better in terms of regression of lesion?
It is the LDL level.
Okay.
Anything which can bring your LDL right down, less than 1.4, can cause regression. I'm not for pharma. If you can do it with just eating grass, well and good.
Already.
grass also, you will still be too high. You only drop your LDL about 30%.
Yes, I know that.
Is CT coronary a reliable test for acute chest pain?
Kanan, you want to answer that?
I think the answer is yes. If the chest pain is suggestive for coronary artery disease, or if you are highly suspicious there's coronary artery disease, CT angiogram is probably the most reliable non-invasive test that we have today.
The good thing about a CT scan, you can also do a triple rule out if you want to rule out aortic dissection or acute pulmonary embolism. So, those patients will also present with acute chest pain. So, in that sense, I think it's also a good modality.
But can I just add, for ACS patients, sometimes a normal CT coronary might not be able to rule out significant ischemia as well. So if you do CT scan because you want to rule out pulmonary embolism, dissection of the aorta, but CT coronary, can we actually rule out ischemia, ACS patients who come to the ER?
It is possible if the thing involved a very small blood vessel, you may not be able to see it on the CT angio, number one. So you still have to go by clinical parameters, your cardiac biomarkers, ECG changes, etc. Number two, sometimes there are also, you may miss it. You may be a false negatives. It's not 100% test, unlike an invasive coronary angiogram. So again, what my colleagues have all said, look at the patient, listen. If it is cardiac and this is supported by ECG and biomarkers, then you need an invasive test.
Could acarbose be used in pre-diabetes as per STOP NIDDM?
Short answer is yes, but it doesn't change the cause of their pre-diabetes. You stop it, then they are back to their IGT status. So it has gone off the flavor because it needs to be taken 3 times with each meal. That's how it works. So we don't use it that much.
So are you trying to say, SP, that if I take Metformin 850 BD, there's a chance after a period of time I stop it, I may not progress to diabetes?
That's also a very good question. We don't think so. Unless you have, in the meantime, while taking metformin, you have also changed your lifestyle, lost weight, become more physically active, then chances are yes, you can stop it and you'll be fine. But if you have left yourself just expecting the tablet to do all the work, when you stop the medication and you're just as big and unhealthy, you've just delayed the process.
I think that's all the questions. Okay, I'll now show the points. I think that's what everybody's waiting for. Give me a second. Okay, so just a reminder, the QR code we're going to show in a little while will be valid only for about an hour. And in case you have caught this talk a bit later on when it's no longer live, you can still claim your points, your CBD points, if you have been paying attention to the code words which have been displayed throughout the session. And what you need to do is click on the link to the bulletin board, which is in the YouTube video description, or you just go to our dops.my/forum and go to the CME section after logging in, and then you locate this talk, and the MCQ module is already up and running and ready for you to claim the points by just entering the code words in the correct sequence according to the MCQ, okay? All right, without further ado, let's see if it works. And this is the QR code for CBD points for today. Working? Everybody got a point?
Yes. Okay, thank you very much, everybody. And thanks. Seems to be
Thank you. It's a powerhouse cardiology team. So many people, and one endocrinologist. One
Yes,
endocrinologist. Sorry.
Metabolic.
Yeah. I got a lot of questions. Got a lot of questions for the diabetes. Okay.
Thanks a lot, everybody.
Thank you, everybody, for attending. Yeah. Thank you.
Okay,
All right.
now I need to go back in because I want to get on my photographs.
Okay, I'll end the broadcast. All right.
19, you know.
Online
calculator. 19.
Oh, that's right. So I was wondering how Canada got so high.
30. That's what I was thinking, you know.